I'd like now to introduce Professor Christoph Nienaber, our next speaker, who is a well-known consultant cardiologist who joined the Royal Brompton Hospital in 2015. He's much respected for his wide knowledge of methods of diagnosis and non-surgical treatment of acute aneurysms of the aorta and other blood vessels. At present, he's concentrating on developing internal stenting of vessels. We are receiving many inquiries on our helpline about what treatment options are available for aneurysm patients in 2025-2026. And we hope that Professor Nienaber will update us and also help answer your questions, which we have encouraged you to bring to his talk. So Christoph, the stage is yours. Away you go.
Thank you very much, Anne and Victoria, for this very kind introduction. And I had difficulty to recognize myself with all these praises. But again, I'm very interested to talk directly with patients, communicate with patients, because I know that you all in the audience are very knowledgeable about your condition and every condition, all the conditions around the aorta, which may be important for prognostic reasons. And as Anne kindly introduced already, there is new concepts basically in the pipeline to diagnose, to treat, to follow, to survey a patient with a diagnosis of an hereditary connective tissue disorder. And I wanted to start my talk, which I'm going to share with you now, with, can you see it now?
Yes.
Oh, it is. Okay, perfect. So I called it, as a subtitle, Importance of Research around the topic of aortic dissection, which affects anybody who is affected by Marfan's as well, as you all know. As a little lead in, I wanted to make you aware of a fairly recent figure of the increasing incidence of patients suffering from dissection and aneurysm in the Western world. Similar slides have been generated for Asia and for Europe, but this is the most recent one, a pretty solid one from Canada. What you can see and conclude that over the years, due to changes in the demographic profile, patients actually grow older, and better diagnostics, you see an increase in the incidence and proportion of patients with these acute aortic conditions such as dissection or acute aneurysm. The problem here is that it's not really readily diagnosed yet. This is a survey from the UK, which I had the pleasure to participate in. Dr. Salmasi, a junior doctor here at Brompton at the time, collected the data from a survey and found out that 30% of all cases of acute dissection are misdiagnosed on the first medical contact. So if a patient presents with crushing chest pain and obvious signs that shouldn't be overseen, he still doesn't get the privilege of an immediate diagnosis, but every third, so to say, every third case is misdiagnosed initially and needs a revamping of his diagnostics, his CT scan, in order to diagnose the actual presence of a dissection. And that takes time, as you can see. With time lost to the proper diagnosis, of course, the risk of complications and even death from this acute situation is increasing. The numbers are not relevant here. The important message is that almost 1/3 of these patients in the acute situation are not diagnosed properly, and that costs time, and time is life in this situation. My talk is basically segmented in 4 little segments, and I wanted to introduce some aspects that are currently in discussion and that are currently basically not necessarily all implemented yet, because we are talking about a bleeding edge research result in some of these four segments of my presentation. So it is something that is going on, that is being refined and partially already offered to our patients, but not necessarily in the guidelines yet. So let's start with non-invasive diagnosing of an aortic condition. It is important, and I encourage everybody who has time to dig deeper, to read the guidelines of the EACTS and STS committee published last year in April, a good year old, but probably the most recent information available to date, that came up with a concept of viewing and interpreting the aorta as an organ by itself, the 27th organ of the body. It is interesting to understand this concept of seeing the aorta as an organ, because it makes it much easier to understand the symptoms of acute aortic dissection, because all the symptoms are related to the affected parts of the aorta and the associated side branches. So for instance, if somebody presents with a stroke or with sudden blindness with dissection, then you with acute pain, that you can conclude that one of the head vessels must be part of the dissection process. So another patient may have a cold leg, and this is due to the fact that with the dissection, one of the legs is not properly perfused anymore. All this is easier to understand if you comprise and comprehend the aorta as an organ with various side branches. That makes it easier to understand the symptoms. Also, this graphic shows you which particular imaging modality is best for the respective part of the aorta. For instance, for the ascending aorta, you need an echo. You don't necessarily need an MRI to diagnose a problem at the level of the aortic valve or aortic root. Whereas in the descending aorta, the echo, of course, doesn't really help, and you need CT or MRI. So that's important information alongside the anatomy of the aorta seen as an organ. This is just an introducing. This shows you that this organ is moving. This image on the right-hand side is a reconstruction from a dynamic CT image, which is a new technology available now, where you can see the dynamics and motion of the aorta in 3 dimensions. It's turning up and down, it's swiveling, and it's also laterally moving in 3 dimensions. That causes sometimes problems with stents. You see on the left-hand side that a patient was properly stented. You see that middle segment of the aorta, but with time, 16 months, the erosion kicked in from this motion of the aorta against the stent. So this is just insight how the aorta as an organ moves in the chest. Another important recognition over the last couple of years was to not only look at the width of the aorta in order to predict some problem in the future, such as the need for surgery or the risk of dissection, but also to look at the length between the aortic annulus, which is the level of the aortic valve, and the first side branch, which is the brachiocephalic artery. So if that length is longer than, let's say, 11.5 centimeter, obviously, based on retrospective analysis of data banks, the risk of future dissection and problems is exponentially increasing, as shown on the right-hand side. So it's not just the dimension in the width or the diameter, but also the length of a certain segment of the aorta. I was involved in a little commentary to this problem, and I looked at the literature so far available onto this length measurement, and it seems to be quite consistent that it's worthwhile to also measure the length of the aorta, at least in the ascending segment, to come up with a sort of risk prediction score. The next chapter of my little talk today is to talk about new therapies in acute aortic conditions. How do we manage patients with this condition in the future? What role does pregnancy play here? And do we actually apply endovascular strategies in acute settings of patients with Marfan syndrome or other forms of hereditary connective tissue disorders? And I think this is an evolving field, and there's new data that I'm going to show and share with you. Of course, we cannot start without mentioning this revolutionary new surgical technology, which was introduced about 35 years ago by Sir Magdi on the left-hand side and Tyrone David on the right-hand side, who both developed independently and repair and resection or replacement of the aortic root and ascending aorta while leaving the biological valve in place. This is possible not only in chronic conditions, but increasingly also in the setting of acute aortic dissection involving the ascending aorta. And the pickup rate of this operation, this particular concept of operation, is more than 26%. recently, as documented in the IRAD registry. So surgeons worldwide use this technology to not only treat chronic condition, but also increasingly acute conditions, which is good because it preserves the biological valve, which may not be affected by the problem. The before mentioned guideline committee came out with an update in the recommendation for surgery as long as the ascending aorta is involved. It's basically always a replacement of the ascending aorta and half of the arch, but increasingly also if the dissection or the entry tear is located more distally, the additional use of an elephant trunk. The elephant trunk is just a name for an inherited or for an adjacent graft or stent graft that comes with the operation and is placed into the downstream aorta in order to stabilize the true lumen in a case of dissection or to seal the entry tear if it's distal to the aortic arch. So increasingly, these more complex operations are recommended even in acute settings. Here are the classic operations for those who are interested or probably were basically patients that have received one of these operations. The most popular is shown in the middle segment of this slide. You see basically a Bentel procedure with an integrated valve. It could be a biological valve or mechanical valve, and the entire root and ascending aorta is replaced by Dacron and will not be subject to further dissection any longer. The concept is always to exclude or close any entry tear. This is sometimes not possible with a Bentel procedure alone, and you need an extended, say, graft, as shown on the left-hand side. You see a replacement of the arch and the ascending aorta. In addition, an elephant trunk pointing down into the true lumen of the dissected aorta and sometimes closing an entry tear which is more distal to the arch. That's essential for the success of the operation. And on the right-hand side, you see the valve-sparing root replacement operation as a concept. You see that the root itself is supported by Dacron, but the valve stays in place. This is possible as long as the valve is not damaged. A newer concept, a preemptive concept of supporting and basically shielding the ascending aorta and the aortic root from dissection is the PIERCE concept. PIERCE is the acronym for Personalized External Aortic Root Support. And you see what it is. On the left-hand side, the model. To the right to it, the graft segment, the graft device that is constructed on the basis of a patient's personal aorta as a model. And then the surgeons uses this personalized graft to wrap it around the aorta of a given patient. And it seems to be very stable. Further progression is very rarely seen. On the right-hand side, you see an example of a patient 10 years after the initial operation with no change in diameter of the slightly dilated aortic root. So on the left of this MR image, you see the aortic root at the time of the PIERCE procedure, and then 10 years later, no change in dimensions, which supports the stability of this concept. Here again, it's shown in more detail. There's a model based on imaging from CT or MRI. The model is constructed and then implanted according to a given need. You see the view of a surgeon in the upper right corner as a standalone procedure or as a procedure in combination with a Ross procedure, which I'm not going into detail at this stage here. But in any case, the wraparound PIERCE graft or sleeve needs to be adjusted to the anatomy of a given patient. It's very personal. That's why we call it personalized graft. It is particularly helpful in patients that run a higher risk of dissection, particularly young ladies at childbearing age. In pregnancy, the risk of suffering from a sudden onset of dissection is statistically slightly elevated. So the PIERCE procedure is offered to patients, for instance, with connective tissue disorders that want to become pregnant and lower the risk or minimize the risk of dissecting during their pregnancy or in the 3 months after pregnancy, in the peripartum. There is a an image like this one here on the right-hand side, very iconic image with a patient with Marfan syndrome who is pregnant in the late stage of pregnancy. You see the fetus, but you also see the dissection, which of course is a disaster at the time of pregnancy. And we want to avoid that by offering this to ladies that are basically suffering from an increased risk of dissection and still want to get pregnant. The latest data have been summarized in a recent publication. It came out this summer in 2025, Connective Tissue Disorders and high-risk pregnancy. It's an observational series of patients that have been offered this Pierce protective device and went through a pregnancy with no complications. So this paper talks about 7 patients, 7 ladies, 6 Marfan patients, 1 Loeys-Dietz syndrome, which got a Pierce procedure prior to a planned pregnancy. The pregnancy went with no problem. The delivery was normal in most cases. A total of 9 pregnancies have been monitored after Pierce in this paper, and all of them went okay, no problem. So we believe that this is a good indication because Pierce itself is not in the textbooks yet. It's not in the guidelines. It's in more or less early stage of clinical application. Let's move now back to the current guidelines, where Pierce is not even mentioned. The guidelines for type B dissection are important to realize. In the past, we thought about type B dissection a little bit ignoring the importance of this disease condition because there was a term uncomplicated type B dissection, which I think is a misnomer. The newest guidelines got rid of this term, and we're talking only of complicated type B dissection. That are those patients with malperfusion syndrome due to one of the side branches affected by the dissection, or by contained rupture of the false lumen, which then is a high risk to die from this rupture. So those are complicated ones. In that case, everything needs to be done quickly, and the patient needs to be operated or stented, or at least under specialist care immediately. And the so-called non-complicated was anything else, which, however, turned out to be a misnomer. We talk instead of non-complicated, we talk about patients with high-risk features. And any patient with high-risk features, but without so-called features of complications, needs attention. The high-risk features are listed here on the right-hand side: a primary entry tear bigger than 10 millimeters, that seems to be a cutoff, primary entry tear of the dissection in the inner curve of the aorta, located closer than 20 millimeters from the left subclavian artery. That's almost always the case. A small false lumen, a true lumen, and a large false lumen of more than 22 millimeters is another important risk criterion. And when the total aorta in the descending is bigger than 40 millimeters. And of course, some flow patterns as well. Persistent pain and uncontrolled hypertension are already well-established clinical criteria. So if one of these or several of these criteria are identified based on imaging or clinical presentation, then the patient can be called a type B dissection with high-risk features and needs treatment, usually endovascular treatment. And I show you here an example of a patient of mine whom I treated at the time of the pandemic 5 years ago as an emergent procedure in a patient, a young patient, 33 years at the time, with Marfan syndrome. We did something we usually didn't do in the past, and treated her endovascularly. There was no option for surgery at the time. You remember the difficulty. And guided by imaging, usually ultrasound on the left-hand side and fluoroscopy, we were able to identify the true lumen with catheters and wires, and eventually you see the maneuvering of wires here in the true lumen and the tiny true lumen here. Eventually placed a very, very flexible and soft, gentle stent into this tissue in a patient with Marfan syndrome and got a perfect result. The patient did very well and left the hospital after a week with no further complaints and is fine in doing follow-up. So this example, under the necessity of doing something in a precarious situation of the pandemic, showed us that this is possible. We are working in an environment that looks like this. This is an OR, but also an imaging suite. So we can do all sorts of procedures up to even open heart surgery in a place that is basically built up for endovascular procedures or catheter-based procedures. So we have all the flexibility and all the experts on board to even use the entire spectrum and armamentarium of interventions. This is now a very important slide that shows you the story of a patient with Marfan syndrome and the need for an operation. But all the operations in this patient over the years were done endovascularly. You see from A to D, various stages during his lifetime, with an initial stent in the descending thoracic aorta, another one later on, the progression of the disease you can see in slide C, and then finally an abdominal stent that shows you the final result over the years. This story is emblematic. A patient with this condition is never completely healed, but needs very good follow-up and for subtle changes. But if those changes are respected and properly treated, the outcome, and you see on the left-hand side the outcome curve after endovascular interventions in patients with only Marfan syndrome, is not so bad. It's actually pretty horizontal or pretty stable over the years. This is 10 years. And the number of patients included in this survey is 81 patients with Marfan syndrome only undergoing endovascular procedures. So I think we are in a critical time or critical point in time where the laws or the recommendations are changing from only open surgical approaches to maybe a combination of surgery and endovascular procedures, or maybe completely endovascular procedures in the near future. This is a similar graph that separates the patient in green that underwent native stenting in their native aorta with no previous surgery, and the one in yellow or in orange are a few patients, 12 patients in total, that had a previous open operation and then later on an endovascular procedure. But the outcome is statistically similar. It shows the patients survive. They need further interventions in the future, of course. This is re-intervention. But as long as they're closely surveyed, their outcome, as I showed before, is quite good. Here's another example, an early example 10 years ago for my clientele, a patient with Loeys-Dietz syndrome after 3 thoracotomies for mitral valve repair and replacement, ascending aortic repair on the left-hand side, developed a dissecting aneurysm in the descending aorta, which could eventually be subjected to endovascular treatment and stabilization. The patient did very well after that. So endovascular, even for patients with hereditary connective tissue disorders, is on the table. And that's also reflected in the American and European guidelines. However, you need a multidisciplinary center. You need a team of people that know what they're doing, surgeons, cardiologists, geneticists, working closely together and offering the patient all the options. As you can see on the right-hand side, all the options from open surgery to endovascular completion or endovascular standalone procedures in order to reduce the risk and to protect the patient from complications. Let's move to the next topic. I wanted to a little bit discuss about genetics and diagnostic confirmation. The role of well-known mutations has been discussed at length. Everybody knows that the FBN1 gene and FBN2 genes code for Marfan syndrome, but there may be place for more than that, like whole genome sequencing. The Marfan features are here summarized in this slide with the known mutations on the FBN1 gene and COL3A1 gene. I don't want to go into details. The previous talks have indulged on that in a very profound way. Similarly, for Loeys-Dietz syndrome, less frequently, of course, seen, the TGF-beta receptor 1 and 2 genes are the ones where we look for mutations. In both scenarios, Marfan and Loeys-Dietz, the ascending aorta in particular is a subject of interest and subject of diagnostic difficulty. You need to identify these changes, sometimes in other areas in the brain or in peripheral arteries, in order to protect the patient from catastrophe. Here's another example, a reconstructed CT image that shows you the tortuosity and the abnormality both in the skeletal system and the vascular system in a case of Loeys-Dietz syndrome. With this in mind, it is important to understand that the combination and the integral interpretation of morphological and genetic features, in other words, the mutation that causes a problem, need to be analyzed together. If you do that, and if you understand that the particular more malignant mutations are present in a case of a slightly dilated aorta, it may be time to operate or to protect this patient sooner than the guidelines previously told you at 5 or 55 millimeters. A patient with a TGF-beta pathway gene mutation or ECM gene mutation may be a candidate for a sooner operation. So in other words, the integration of imaging and genetic information may help to shift the curve a little bit, or the time point a little bit to the left, to a sooner, or let's say in-time operation, rather than waiting to the threshold of 55 millimeters. But this is ongoing research. It's not, the last word hasn't been said. It's not set in stone, but I see a trend of integrating genetic and morphologic information to pick the right time for an intervention. If the mutation is not identifiable because it's either not known or needs to be found on another location, I think whole genome studies will be the next important step in the near future to identify unknown gene mutations, or VUSs, variants of unknown significance, in patients that have morphologic features that may put them at risk. Let's make a little step here to ongoing research beyond the genetics. I think we are talking to patients, and patients are here. The genetics are determined, can't do much about it, but the lifestyle can be changed. The lifestyle of our patients is sometimes limited unnecessarily, I would say. Depending on the phenotypic capacity and physical fitness, a patient with these connective tissue disorders is actually welcome to conduct an active lifestyle. Aerobic sports should be recommended, and ongoing research on this is currently taking place. I'm taking part in a research consortium at the Brompton and affiliated hospitals to encourage our patients to engage in controlled aerobic exercise and demonstrate that the aorta is not endangered by active lifestyle or by regular exercise up to a moderate intensity. We're monitoring those patients that are invited for this exercise, let's say surveyed research, to engage in regular and moderate intensity exercise sport that they like, either cycling or running or jogging, or if the joints allow that, or swimming, but to conduct an active lifestyle. And we want to demonstrate, and so far the data show, that this is not any threat or any risk for the aorta. But this is work in progress. Hopefully next year I will share with you some of the results. I'm pretty hopeful and almost convinced that nothing will happen to the aorta, even if you conduct an active lifestyle. So finally, I want to talk about some new ideas and new imaging protocols that are already put in practice in order to survey a given patient with a condition. We all know that surveillance is helpful because surveillance can pick up changes that are asymptomatic. So if you, as a patient, are invited to be seen in an annual interval, and I hope we don't miss anybody, then you should really take that serious and come and be screened and checked again, either with MRI or CT imaging, because it's important. The growth rate of any kind of segment of the aorta can only be determined by serial imaging. You cannot really predict it unless you have several images to compare and show a trajectory. If the trajectory shows you that the peak imaging stress, or the stress calculated from an image, travels down the aorta, the likelihood of changes and aneurysmatic degeneration or even a dissection is increasing. From analysis of thousands of images, this paper on patients with Marfan syndrome showed that a radial growth rate of more than 0.6 millimeters per year and an elongation rate of more than 2.4 millimeters predict a future dissection. So it is important to pick this up and basically compare images in a long-term trajectory. The images can be based on currently CT. CT has a little bit of radiation that comes with it, but in the near future, I think even non-radiating imaging, such as non-contrast MRI that doesn't even need a contrast agent and no radiation, of course, can come up with similar image quality in the near future and would not expose any patient who is a subject for serial imaging to any radiation, because it adds up over time, and if you can avoid it without sacrificing image quality, I think MR imaging in the future will be the tool to be used for serial imaging over several decades. Four-dimensional MR stress mapping is an interesting tool which is not really used in clinical practice yet. And the idea with this is to convert the images themselves into stress maps, which is almost a miracle to me. But the engineers and the research people have tools to identify the stress imposed onto the outer curve of the aorta with time and with location identification. So in other words, if the stress here marked as red is high in a particular point alongside the aorta or along the aorta, then this particular point is subject to a high local stress and possibly to the beginning or the entry point of a dissection in the future. So this is an example that shows you that this technology will be used in the future for predicting problems alongside the aorta after or before surgery. It's not validated yet. It's just a glimpse into the near future. It's only working so far to describe the effect of an aortic valve, an artificial valve, like in this example. Of course, has some stress onto the ascending aorta, and the various valves have different profiles. And similarly, I think we'll be able to use this technology to predict dissection in the future in patients with a softer aorta or with high-risk features. Finally, this slide summarizes how I personally think we should deal with patients with an aortic condition or with a higher likelihood of suffering in the future from an aortic problem. They will never be completely cured, like Sisyphus never really reached the goal of being on top of everything. But we can help, and we can survey them, we can assist, and we can find a proper treatment, which is more and more being keyhole surgery or completely non-surgical approaches to various parts of the aorta. Thank you very much for your attention. I look forward to answer a few questions.
Thank you so much, Professor Nienaber. Treatment for the aorta is becoming increasingly precise with new technology, and you've given us a glimpse into the future. Thank you very much.
And I wish you could see it, but there's a standing ovation going on. All the people watching your talk, and you can't hear it or see it, but it's there.
No, thank you.
We're all so excited by this work and very, very proud of the Royal Brompton as a center of excellence, and even happier that it's available to the people watching this, because of course, once it's decided that care is required, the next challenge in the UK is to find a center who can do the kind of operation you need. And we're never quite certain how to go about that if a patient contacts us. I guess we just need to keep referring them to the largest teaching hospital near them that we know has a cardiovascular surgical group contained in it. But I don't know, is there any plan in the future for publishing which centers in the UK can do which kind of surgery?
Yes, and there is a so-called toolkit in the process of being put together. It starts in London, and various centers in London have participated in the discussion over the last, let's say, almost 2 years. The toolkit will be rolled out over the entire UK, trying to encourage to form local hub and spoke centers in major cities and adjacent areas in order to make sure that the patient is referred to the right place in a decent time frame. And of course, that in the hub, the appropriate capacity and excellence is available to treat these patients that come with problems, with acute problems. The acute problem is basically what we have to improve, the care for acute problems. Once a diagnosis is established and the patient is under somebody's wings, I think it's less likely that something goes wrong. But the acute first presentation with a catastrophe or with a dissection or with symptoms, I think needs to be improved. And the toolkit is one instrument that will be rolled out very soon under the guidance of my colleague, surgical colleague at Barts, but also with our contribution and participation, and will basically homogenize the care over the entire UK.
Excellent news. And do you have questions, Victoria?
Yes, a stream of questions has just emerged in the chat feed. Jessie used to run a lot, exercise, struggling since her dissection to get back to it. Is the advice around exercise the same one you've already had? And if you're living with an aneurysm and dissection that hasn't been operated on yet, she had a type B dissection last year. It's a bit unusual. It begins in her infrarenal, just by the artery supplying kidneys down to the top of her left leg, and she's been monitored by Professor Colin Bicknell since he operated on her mum before she died. No surgery yet, and he said open surgery if it grows and gets to that. But she's young, and he's keen for her to also be followed up and back in the system at the Brompton. I think she fell out of the system in 2017 when her mother and sister died.
So the question is it safe for her to jog with a dissected infrarenal aorta? Is that correct?
I think that's the distilled question. Yes. Jessie, is that correct? I think so.
Yeah, I think the key is to control blood pressure, to be on the right medication, which would be a combination of a beta blocker and a so-called sartan drug, irbesartan, losartan. And we try to aim for low normal blood pressure, as well as tolerated blood pressure, of course. Usually that is around 100, 105 systolic. If that blood pressure is preserved, even during a treadmill exercise test, which would be our entry to this research project with sports medicine in Brompton, we test the patient on the treadmill, we measure blood pressure, we see that the blood pressure is well controlled even under treadmill or running exercise. Then, of course, we don't restrict the patient from running, jogging, or cycling or whatever, even with a dissected aorta under the threshold of 4.5 or so.
Thank you.
The driver is always the blood pressure, and the blood pressure needs to be well controlled under resting condition and exercising condition.
Definitely. Amanda, I think you know from past information days, has a type B dissection identified in 2020. She was told she should now have open surgery to replace her descending aorta. My risk of dying if I don't have it is currently 10% in the next 12 months. I've so far chosen to take that risk as I'm fully aware of possible complications post-surgery. Is there any prospect of me being able to have endovascular repair in the near future? I do not have an elephant trunk, having had my aortic root replaced in 2008.
Mm-hmm. Well, this needs to be discussed on an individual basis. If the anatomy allows it, and I cannot really comment why open surgery is not recommended or not possible in this case. Sounds a bit interesting, but it needs to be looked at individually. Theoretically, I think she could be a candidate for an endovascular procedure. Although in the textbook, the general recommendation is to stay away from endovascular procedures in Marfan condition, under Marfan conditions. This may change and will change in the near future because we have better technology available, very gentle stents that do not cause too much of a problem, at least in the descending and in the abdominal aorta.
Thank you. And Amy has asked, Amy's husband has Loeys-Dietz. So should we aim for 100 to 105 BP? We were always told as long as it's under 120.
No, the newest data show that the lowest tolerated blood pressure is best. And that's usually my experience, 100. Don't go under lower than 100 systolic. But there's an interesting paper that came out in 2022, an analysis from the UK Biobank and the Japanese Biobank. Both biobanks in Japan and in the UK combined 500,000 patients. So the total was 1 million patients monitored for a certain amount of time. And due to this big number analysis, it was possible to distill the threshold blood pressure that increases the risk for dissection. And that threshold was 130 systolic. So you can show, these authors could show that 130 is not normal anymore because it already increases the risk for a higher incidence of dissection in the years down the line, in the years to come. So you can conclude from this analysis that the lower the blood pressure is, and they found 117 or 118, the optimal blood pressure to not take any risk for future development of vascular problems. So I would say 130 is already too high.
Thank you. Ammar has asked, I do strength training and have been told to limit the increasing of weights. Have you done any type of study into this with people who have Marfan and how it affects them?
Well, that's a very interesting and question that I'm confronted with almost every month from individual patients. They want to go and build some muscle. I discourage that for various reasons. First of all, we know that with weight training and resistance training, the blood pressure can spike. And that's probably counterproductive and should be discouraged. On the other hand, you don't need to be inactive or conduct a sedentary lifestyle if you have a condition like that, and rather engage in aerobic exercise up to a moderate severe level if you're well trained and well conditioned. But weightlifting causes sudden spiking systolic blood pressure, which is counterproductive. Although the data is very slim, the database is very slim. For my gut feeling, I would not recommend it. We are trying to establish slowly data to support aerobic exercise, but there's a long way down to come to the conclusion that resistance training will be also very benign and very risk-free or with a very low risk. We don't have that data, and so far we would not recommend that.
Thank you. And Jaswinder has said, you've talked mainly about the aorta. What about the other vessels too? As I believe in Loeys-Dietz, her son has Loeys-Dietz, other parts of the arterial system. Is there a risk of dissection in any other vessel than the aorta if you've been identified to have an aneurysm in the subclavian artery?
Yeah, there is a certain risk of other segments, other segments of the arterial tree in the body are affected, particularly in Loeys-Dietz. We can go back to the slide that I showed. It shows an aneurysm in the cerebral artery, another one in an arm artery or in the femoral artery. That's why we screen in the condition of Loeys-Dietz every 5 years with a full body arteriogram, if you want, and look at various vascular beds in the body to identify a new local vascular pathology such as an aneurysm, which is silent and symptom-free, whereas a dissection is usually symptomatic. So that's part of the protocol every 5 years to screen for newly formed aneurysmatic changes in the body all over from top to bottom.
Thank you. Thank you very much. That's perfect. Would you be able to share a link to the paper you mentioned on the UK Biobank and Japanese research a patient has just asked?
Yeah, I can do that. Probably not now. I need to see whether I can find it quickly. I can send it to you and you can distribute it, of course.
Yes, when I share the videos.
Is that okay? I sent the paper and the commentary. I wrote a commentary to it, and it's actually very nice. I adore this paper. It's one of the most important papers in the last 5 years I've read, because due to the fact that so many patients, a total of 1 million patients from 2 different gene pools, UK and Japan, different gene pools, showed identical information, and together the message was even stronger that a certain level of systolic blood pressure, which was previously considered to be still normal, could be dangerous.
Fascinating, thank you. May I just sneak in one further question? Someone's emailed me. She said it's rather random. It's about bouncy castles. Her son has confirmed Marfan syndrome. He's 4, and he's being told to resist the trampoline. Does it follow on that he probably shouldn't go on bouncy castles either?
Okay, what can I say? I mean, kids at the age of 4, I mean, probably they tolerate everything, even with a condition of Marfan. I would not be too resistant or too restrictive to let them play trampoline or whatever. Trampoline is dangerous to begin with, but probably not more dangerous in a patient who is affected by a faulty Marfan gene. So it's hard to comment. It's probably more traumatic for the kid not to participate in this activity than a precaution to avoid any problem with the vasculature at that age.
Thank you. That's very helpful, and thank you again. We've run over, and which is a good sign because we've been flooded with questions. So thank you so much, Professor Nienaber.
Thank you, Victoria. I will share that publication from 2022 and the commentary with you as soon as possible.
Excellent. Thank you. Thank you so much. Bye-bye.
Bye-bye.